We are the Association for Child and Adolescent Mental Health, or ACAMH for short.
Hello and welcome to the Papers podcast series for the Association of Child and Adolescent Mental Health, or ACAMH for short. I'm Mark Tebbs and I'm a freelance consultant. Today I'm really pleased to be talking to Dr. Jacqueline Sampson and Dr. Martin Teacher, who are the lead authors of a paper entitled Practitioner Review, Neurobiological Consequences of Childhood Maltreatment, Clinical and Therapeutic Implications for Practitioners, recently published in the Journal of Child Psychology and Psychiatry. Welcome, Jackie and Marty. Lovely to be speaking to you today.
Thank you. Same here.
Thank you, Mark.
Good stuff. So you're the lead authors for the paper. So if we could start with just, if you could introduce yourself, and I think you worked with another colleague, so if you could introduce them at the same time, that would be great.
Sure. Okay. I'm Dr. Jacqueline Sampson. I'm a clinical psychologist and research associate at McLean Hospital in Boston area, and an assistant professor of psychology in the Department of Psychiatry at Harvard Medical School. My chief research interests involve understanding the underpinnings of depressive illnesses and especially the contributions of developmental trauma to psychopathology. My colleague, Thatcher Newkirk, who is not here with us today, well, at the time that we began this project, Thatcher was a fourth-year resident in the psychiatry residency training program at St. Elizabeth's Hospital in Boston, completing a year of directed research with me. He went on to complete a geriatric fellowship at Dartmouth and is currently a clinical instructor in the Department of Psychiatry at the Geisel School of Medicine at Dartmouth University and Medical School, and on staff at the Dartmouth Hitchcock Medical Center.
Okay, I'm Martin Teacher. I'm a psychiatrist. Been at McLean Hospital for a very long time, where I am a research psychiatrist and run a research program called the Developmental Biopsychiatry Research Program. I'm also a senior faculty in the Department of Psychiatry at Harvard Medical School. My focus in the research has been very much on the effects of childhood adversity on brain development and risk for various psychiatric disorders. Also done a fair amount of research on the neurobiology and treatment of ADHD and depressive illness, and looking forward to talking today.
Likewise, thanks for the introduction. So let's start with just a brief overview of the review paper, just to kind of set the scene for our listeners.
So the title of our paper is a Neurobiological Consequences of Childhood Maltreatment, Clinical and Therapeutic Implications for Practitioners. And the purpose of it is threefold. First, our hope was to provide a summary of what is known about the neurobiological consequences of exposure to maltreatment in childhood. The second, to discuss what problems we might expect to see behaviorally in individuals exposed to childhood maltreatment. And third, how we as clinicians might help patients who have been exposed to maltreatment overcome these problems.
Thank you. So if I could sort of take you back to the start, could you describe and just unpack a little bit your original research aims, some of your original hypotheses?
In 2013 and 2016, our group published a comprehensive or several comprehensive reviews of research linking exposure to childhood maltreatment with alterations in brain structures and circuitry. For me, working on these reviews while continuing to treat patients who had these types of histories, it created a new frame for my clinical work, and I found myself talking with patients about emerging findings observed in groups of maltreated individuals. My patients were extremely interested in learning more about this, and together we talked about the implications of the neurological alterations found in the MRI studies that were included in these reviews, and how they might dovetail with some of the behavioral struggles my patients were having. So the clinical areas we've chosen to highlight in this paper were selected specifically because they reasonably connect with the altered brain structures reported in the literature. We haven't discussed a variety of other symptoms that have been included in descriptions of developmental trauma or complex PTSD that have been based on clinical observations alone. And in this way, we've attempted to begin to develop a clinical toolkit that is specifically assembled to identify and address some features found in patients exposed to childhood maltreatment that are reasonably speculated to be associated with reported brain abnormalities in this population. Secondly, in our clinical experience, we have found that including discussions that are age appropriate, of course, of these reported brain abnormalities, those that might be reasonably speculated to be associated with certain clinical presentations, helps to provide a rationale that may make the clinical interventions more understandable to the patients and to their families. Now, I do want to point out that we do not see these symptoms as equivalent to a diagnosis of complex PTSD, although there is overlap. Not all persons exposed to childhood maltreatment do suffer from PTSD. And it's possible that maltreatment may be ongoing and damaging, but not acutely life-threatening, such as people who've been exposed to chronic emotional abuse or emotional neglect. Or the trauma exposure may not be remembered or may not emerge until much later in life. So we're proposing here a toolkit that may identify clinical interventions to be used for various other behavioral symptoms that may present episodically or sporadically in individuals exposed to childhood maltreatment, but likely don't or may not meet criteria for PTSD.
Is there like a personal or professional connection to the research field? I'm just wondering whether you were trying to address a particular research gap, or is there a kind of a central research question that you were trying to address?
Well, when we began this work, we asked clinicians the question, what are the best treatments for individuals exposed to maltreatment as children? And the answer we usually received was, oh, trauma-focused CBT. And when we went on to start our literature review and look into it a little bit more, it became clear that exposure to childhood maltreatment does not constitute a diagnosis. It defines a population at heightened risk for developing psychiatric or physical disorders and a wide variety of behavioral presentations that may bring these individuals into treatment. In and of itself, it's not a diagnosis. So while there is now a convincing body of evidence that supports the effectiveness of trauma-focused cognitive behavioral therapy and other trauma-focused interventions, including EMDR, for the treatment of PTSD in children and adolescents, it's unclear how effective these modalities are in treating the vast array of other psychiatric disorders that emerge in maltreated youths. In the paper, we quote a Cochrane review of treatments for children and adolescents exposed to trauma that reported most PTSD treatments studied produce moderate improvement for PTSD symptoms, but also note that the outcomes for subjects with exposure to trauma who did not meet diagnostic criteria for PTSD were less favorable than the outcomes for those diagnosed with PTSD. So addressing a similar issue, other outcome studies of adult PTSD treatment identified subsets of subjects meeting additional ICD-11 criteria for complex PTSD, and these resulting meta-regression analyses revealed that subjects with complex PTSD did not respond as well to standard PTSD treatments. So even though there were a number of treatments that are known to be effective for addressing the specific symptoms associated with PTSD, not all maltreated children develop PTSD or even meet criteria for complex PTSD. So in fact, some reports we reviewed in the paper have shown that only 35% of severely maltreated and psychologically traumatized children have met structured interview criteria for PTSD. So then the question changed a bit and became, how do we treat these other sequelae of exposure to childhood maltreatment? And another question became, what are the behavioral problems we would expect to see in children and adolescents experiencing the neurobiological alterations reported in the literature, and how might those be treated? So this review addresses these last two questions.
Okay, brilliant. So we come on to the toolkit and the clinical implications in the second half of the podcast. I think it'd be useful if we focus this next bit on those neurobiological changes. So the paper's divided into those two main sections. So the first describes the kind of alterations in brain structure. The second half then summarizes the behavioural presentations associated with those neurobiological alterations. So I'm going to suggest we kind of follow that format for the rest of this podcast. So could you start by explaining how childhood maltreatment alters threat detection and the response in the brain?
So one of the fascinating things that we found in doing research on the effects of childhood maltreatment on brain structure and function is that many of the regions that have been identified as being different in individuals with maltreatment histories are all part of a circuit that plays an important role in detecting and responding to threat. This circuit was laid out a while ago by Joseph Ledoux. It's been amplified by a number of people, and it's a very sophisticated circuit that picks up salient stimuli, and one of the most salient stimuli that it's concerned with detecting, are threats. And what's sort of central in this circuit is the amygdala, and there's two pathways from the sensory systems to the amygdala. There's a direct pathway that goes very rapidly to the amygdala, and there's a longer, more complicated path that goes through sensory cortical regions and to other limbic and prefrontal cortical regions that takes longer to process the information, but then can moderate the response. So we can have one level of response at an unconscious level where we detect something that's a threat and we respond immediately, like we freeze or something like that. And then as the higher processing regions come through, it may then help us realize that it's really not a snake that we're looking at, it's really a stick, and that we can, take a deep breath. It's just interesting how almost every component of the higher part of this pathway is shaped and affected by exposure to childhood maltreatment. The most interesting wrinkle that's come out most recently is that these brain regions have sensitive periods when they're particularly susceptible to different types of maltreatment at specific ages, and that the number of these regions, like the amygdala and the hippocampus and aspects of the prefrontal cortex, have two sensitive periods. They have an early sensitive period in childhood, and they have a later sensitive period in adolescence. They're modified by exposure to maltreatment during both of these windows of vulnerability, but in opposite ways, so that exposure early on will lead to an enduring effect on the amygdala to blunt the amygdala's response to threat, whereas exposure during the adolescent period will actually wind up enhancing the amygdala's response to threat. And that these probably have adaptive significances that, an adolescent, a 16, 17-year-old who's responding to threat can, mount an appropriate fight or flight response, whereas, a 6-year-old isn't going to be able to manifest an appropriate fight or flight response and may need to actually submit and self-soothe, and that if they actually had too much of a fight or flight response, it might actually disrupt the attachment bond. So that, they have these changes, and these changes are, the brain isn't damaged by these things, it's modified by these effects, and these modifications are probably of adaptive significance and helpful in childhood. But later, as you go into adolescence, as you go into adulthood, there can be, significant ramifications from these changes that set you up, to develop different psychiatric disorders and vulnerabilities.
And so the paper then describes the kind of second impact of childhood maltreatment on the area and integrity of the white matter tracts. Could you explain that a little bit for us?
So maltreatment is affecting, as far as we can tell, all aspects of brain development. So what I was just talking about are, effects on the brain regions, which are, called the gray matter portions of the brain. And then there are white matter portions of the brain where there are fiber tracts. These are myelinated fiber tracts that interconnect brain regions in which signals go, between the brain regions. And that there's this substance called myelin that wraps around neurons and facilitates neurotransmission. It's very important for rapid neurotransmission. And the production of myelin can be affected by stress, and you can get alterations in myelin. You can also get alterations in the inner integrity of the axons. So not only does it influence the structure and connectivity of the neurons, but it influences the flow of information from brain region to brain region. And interestingly, there's pretty prominent sex differences in what gets affected. Found, for instance, in the corpus callosum that in females, it's primarily affecting myelination, whereas in males, it tends to be more affecting the integrity of the axons themselves. So interesting how they're both affected, but in somewhat different ways.
Okay, and what happens in relation to the hippocampal and the kind of subfield activation?
So the hippocampus is one of the most stress-sensitive structures in the brain. It's sensitive in two ways. One portion of the hippocampus is called the dentate gyrus, and the dentate gyrus is a portion of the brain in which there's active postnatal neurogenesis. So there's production of new neurons coming into this portion of the hippocampus and getting to some degree integrated. And this can be really suppressed by exposure to stress or adversity. And then there's also the large neurons in the hippocampus called pyramidal cells because they have like a pyramid shape. And these neurons are affected by stress, which can affect, the complexity and the dendritic branching of these neurons. This is one of the major targets. These neurons are found in the hippocampus, they're found in the amygdala, they're found in the prefrontal cortex, and they're, portions of the brain that are particularly vulnerable, to stress. And the hippocampus plays an important role in the threat detection circuit, modifying the amygdala's response. A portion of that, the subiculae, particularly involved in modifying response to psychological threats. It's also plays an important role in learning and memory, particularly retrieval of information and in spatial navigation. So there are myriad consequences from affecting the hippocampus.
The paper talks about the concept of latent vulnerability. Could you describe and explain that to our listeners?
This idea of latent vulnerability has been advocated by Eamon McCrory in a very nice paper in the Journal of Child Adolescent Psychiatry and Psychology in 2017. And he talks about maltreatment as affecting a number of brain functions like threat detection or reward response or short-term memory. And that, as Jackie was saying, it's not directly tied to pathology, but it's associated with a latent vulnerability where down the road you may develop a psychopathology. We see this very nicely in our data that we can find these abnormalities in brain structure, and they correlate rather modestly with current symptoms, but they correlate very strongly with lifetime risk for developing different psychiatric disorders. It's a vulnerability that's not necessarily manifest, but could be manifest. And so you're at risk for developing a host of different disorders because of these things. And that degree of separation between how the neurobiology has changed and what you see clinically is quite important. I think it's also important that it means that there's also ways to preempt the onset of psychiatric disorders in individuals who've been exposed. And that's something that we need to learn much more about.
And the last bit of the kind of neurobiology section of the paper kind of reviews the evidence around ecophenotypes. Could you just describe what those are for maybe listeners that don't understand and explain the impact of maltreatment?
Jackie and I wrote a paper back in 2013 where we made the hypothesis that maltreated and non-maltreated individuals with the same DSM or ICD diagnosis are actually clinically and neurobiologically distinct. And that even though we're giving them the same diagnosis, that we might call both give them a diagnosis of major depression, that they're very different. And in particular, the individuals with the maltreated variant, which we call an ecophenotype, have alterations in the morphology and connectivity of stress-susceptible brain regions. They also tend to have an earlier onset, a more severe clinical course, more frequent comorbidities, and poorer response to first-line treatments. And the difference in response to first-line treatments can be quite dramatic. It can be the difference between 80% response and 16% response between the phenotypes. And we talked about this in terms of depression and anxiety and substance use disorder, but it extends beyond that. It's also now been observed in schizophrenia. It's been observed in bipolar illness. There really do seem to be important variations between these individuals who do or don't have a maltreatment history. And we really were trying to advocate that it's important for clinicians to note this. It's important to keep records of this. What may be recommended as a first-line treatment for the average person may not work all that well in the individuals who have a maltreatment history. So we have a lot to learn about this subtype and how it compares.
Thank you, Marthy, for that kind of comprehensive coverage. Jackie, we're going to move on to the clinical implications. And I'm going to ask you the question that you kind of pose yourself in the paper. So what are the problematic behavioural presentations would you expect to see in individuals exposed to childhood maltreatment?
Well, we might expect to see symptoms such as functional alterations in threat processing. And what we mean by that is either overreacting or underreacting to threats in the environment. We might see less conscious awareness of the actual environmental threat that exists, but at the same time showing a preserved unconscious behavioral activation of the threat response, showing behaviors such as fight, flight, or freeze, but without knowing why these behaviors are coming up. We might see problems with accurately integrating signals from the left and the right hemisphere, with the left hemisphere having signals that have to do with describing what is happening just in terms of the details and the particulars of the moment, and the right hemisphere picking up on the emotions or the implications of the moment, and the patient having a hard time integrating these signals and possibly toggling between states of unemotional recounting of information, flipping over to a state of affective flooding. We might see things like a negative cognitive mindset. We might see overgeneral memories or fewer memories of personal experience, or what we call in the field autobiographical memory. And as a result of all of these kinds of problems, we might see difficulty learning from experience. We might see difficulties interpreting social interactions. We might see poor judgment. And we might also expect to see problems with affect regulation and difficulties maintaining relationships, what Eamon McQuarrie has referred to as social thinning. And lastly, we might expect to see diminished response to reward anticipation and reward receipt, or what some might call anhedonia. But on the other hand, hyperresponsivity to potent rewards such as drugs of abuse or risky rewards.
In your introduction, you mentioned the list of evidence-based tools for treatments. Could you kind of describe those a little for us?
Well, we'll start with actually in many ways, the most important, which are tools for an overactive threat response system, which I think we describe in the paper as probably the overall biggest issue one sees in persons presenting with a history of maltreatment. For those, we're recommending lifestyle type changes that would result in an overall decrease in the level of arousal or the level of anxiety the individual is feeling. Things such as daily positive mental health practices that encourage a more resilient baseline, daily sleep hygiene, because quality of sleep relates to the effects of maltreatment on hippocampal and the growth and integrity of myelin in the unsnit fasciculus, the things that Marty was speaking about earlier. Daily structure and minimizing stress exposure in order to help maintain an optimal level of stimulation. Behavioral practices such as paced deep breathing on a daily basis, attention to breath exercises, progressive muscle relaxation, mindfulness training, and physical exercise, which has been shown to improve executive functioning. In addition to specific lifestyle practices such as these, specific behavioral treatments could also help. Among those would be dialectical behavior therapy, training skills, modules for distress tolerance, emotion regulation, interpersonal effectiveness. Training relying on cognitive reappraisal and biofeedback could be helpful with older teens in order to gain a greater control over amygdala reactivity. And for young children, ARC affect modulation exercises might be helpful. Neurofeedback procedures can help reduce amygdala reactivity. Moving on to tools to identify the source of activation for individuals who don't have information coming in from what we refer to in the paper as the high road or the higher cognitions that have to do with sensory input and conscious awareness. In therapy, a key goal would be to identify and manage the triggers in the environment. In order to do this, a therapist can ask about the most recent previous time the patient felt quote unquote normal, and together with the patient, identify each and all activities, including books, movies, internet, conversations, thoughts, and exposures that have occurred since the time the person started to notice a difference in feeling activated, in order to create hypotheses about the potential sources of perceived threat. Identifying patterns in content over time can go on to help the patient and those who care for them too, because they're going to be part of the team, become more alert to environmental triggers and work on anticipating them. And this kind of approach is consistent with Carrion's cue-centered therapy for child and adolescent complex trauma. More tools for toggling between verbal logic and emotional states. One of the most problematic correlates of this kind of toggling may be getting triggered into a state of extreme emotional intensity without the ability to access linear thinking or verbal abilities, meaning patients might become flooded with affect and find themselves unable to put their experiences into words. So if you ask a patient to write about their feelings, that can be a good check on their ability to access verbal logic. If they can't write and if they can't describe it, put it into words, they probably need to focus on self-soothing activities using nonverbal methods, similar to emotion regulation skills outlined in DBT. Only when the patient is more settled can you try to access verbal abilities and introduce activities that involve logic. Puzzles, non-emotional and distracting mental activities may be helpful then. Many patients can actually feel the shift in affect and describe that the emotional outburst has passed, and these rapid shifts in mood can be addressed. And lastly, a word on the working alliance. Establishing a consistent and affirming working alliance can create the base for building more positive social expectations. This may be both the most critical and the most difficult component of the treatment regimen. Childhood neglect and physical abuse are predictors of adult anxious attachment styles, avoidant attachment, and problems with depression, anxiety, poor self-esteem. Some brain areas noted to be altered in maltreated individuals have also been cited as central to social processing in individuals with insecure attachment styles. Extensive discussion of relationship models and modules for addressing maladaptive connections can also be found in the treatment manual for stair narrative therapy by Poitras et al.
Thank you. So I'm just wondering whether it's possible to summarize how knowledge about alterations in brain functioning changes the clinical approach to treatment.
I think the best summary would be to say that it can reduce blame for behaviors that may be extremely difficult for patients to change or control. This framework links neurobiology to clinical presentations in a form that we hope will enable clinicians to convey to their patients that there is good reason to believe that maltreatment can result in neurobiological adaptations to the brain that can make it difficult to function well at times and help to reduce blame for behaviors that may be extremely difficult for them to change or control. If we understand that this is indeed the case, then there is a starting point for a compassionate discussion about not necessarily reversing these neurobiological changes, but finding ways to compensate for them.
Thank you for that, Jackie. I just wanted to turn us a little bit to the research field. So is there any further research that you think is required in the field?
Oh, sure. There's a great deal of research. We're working on a number of things. It's really nice to see that how many people have also doing research in this area. When I started, there were basically just 3 groups, doing it. And now it seems like every medical school and every major psychology department has somebody doing research in this area. So it's exploding in terms of the the number of publications. From what we're doing, we're still doing more in terms of understanding the neurobiology, and I think we can pretty much put together soon a more comprehensive atlas of the brain regions that change and be able to make some predictions. One of the things that's been particularly interesting is looking at brain changes in those individuals who are symptomatic and susceptible versus those individuals who appear to be much more resilient and don't have problems with psychiatric disorders. Interestingly, we noticed that there's also a lot of brain changes in the individuals who are resilient, also trying to understand what specifically changed in those brains of individuals who have recovered. And I think that will give us more clues as to what we can do therapeutically to foster recovery. We're working more on the ecophenotype hypothesis. We're looking at it particularly in terms of substance use disorder, the idea that there's one major pathway through substance use through maltreatment, and the individuals who don't get there through that pathway often get there through an ADHD pathway, and that because of these different subtypes, they may need different approaches to treatment. We're also looking within ADHD at subtypes of ADHD, where we can find differences between individuals who've had no exposure to maltreatment and those who've either had very history of early neglect or those who have maltreatment later after they've had an ADHD diagnosis. The ones with very early neglect tend to have neurocognitive problems not seen in the other group, and they tend to be less hyperactive, whereas the individuals who have exposure to maltreatment, particularly during the adolescence, often wind up with high levels of comorbidity, and they may be 3 to 5-fold more likely to develop, comorbid disorders than the ADHD individuals without maltreatment. So I think that's helping us to understand comorbidity in ADHD. In terms of treating the disorder, there's also a need to really focus on the underlying mechanisms. How much are these alterations in the brain mediated by processes such as inflammation or stress hormones, because that may also give us, targets for intervention. And we're also doing studies to look at how different types of treatments like mindfulness, doing this work with Diane Joss and Sarah Lazar, looking at how mindfulness meditation alters the structure of these regions in individuals with maltreatment history, hopefully to move on and do these studies looking at this in terms of DBT and maybe down the road psychedelics. So I think there's a whole exciting array of research that can be done. I just wish I was younger. But sure, it's going to be great with all the things that are going to get discovered.
Yeah, amazing. Very, very active, exciting field. So, so we've come to the end of the podcast. Is there like a final take-home message for our listeners?
If you are a person who has been exposed to substantial maltreatment, there are treatments that can help with some of the problems you struggle with. And your struggles may be more difficult than those of the average person due to stress-induced changes in the way your brain works. For practitioners, even if they do not have PTSD, your patients with maltreatment are likely to be feeling overwhelmed by demands for managing innate behavioral responses shaped by exposure to adverse environments, and may require specific treatment and skills training to compensate for neurobiological alterations that have occurred. And lastly, for researchers, not all individuals exposed to maltreatment in childhood present with PTSD syndromes. And the challenge is to understand the neurobiological underpinnings of exposure to maltreatment in childhood and to identify factors that can interrupt progression into serious mental and physical disorders.
Thank you so much for your time and for such an interesting discussions today. So for more details on Dr. Jacqueline Sampson and Dr. Martin Tetzschner, please visit the ACAMH website, www.acamh.org, and Twitter at ACAMH. ACAMH is spelled ACAMH. And don't forget to follow us on your preferred streaming platform. Let us know if you enjoy the podcast with a rating and review, and do share with friends and colleagues.